Hi everyone, welcome back to freepilotgroundschool.ca. We're going to begin our first lesson on human factors and aviation physiology. So you might be wondering, what in the world or why do I need to know this information? So many years ago, accidents happened and nobody really investigated. It was just like, oh, that's too bad, bad accident happened. But then in approximately the 1970s, regulatory agencies, pilot unions, airlines all started looking at why some aircraft were crashing, that there was really no mechanical failure, and most pilots could have prevented that crash. And so what started emerging was the study of human factors. So this was a well-qualified crew. The airplane was working just fine, and all of a sudden it crashed. Why did that crash? And back then what they did is they would just chalk it up to pilot error. Oh, well, that's too bad. The pilots made a mistake. Some people died. And then they started realizing that the concept of pilot error was unduly narrow, that in reality, a lot of accidents had a number of factors involved. Let's just say the pilots were fatigued. Well, why were they fatigued? Well, they were fatigued because they had circadian rhythm disturbances. And then this issue ended up compounding itself to the point where the pilots were no longer able to make a satisfactory decision, and the plane ended up crashing. And so the subject of human factors was born, and there's a considerable amount of emphasis now on human factors in all levels of training. So let's get started with our first lesson on aviation physiology. There are a number of smaller subjects within this kind of major subject of aviation physiology. So kind of similar to flight operations, we'll seemingly jump from one to another, one subject to another. So let's begin with hypoxia and hyperventilation. Hypoxia is when there's insufficient oxygen to the cells in the body. And there are a number of different types of hypoxia. The first one, hypoxic hypoxia, which is insufficient oxygen in the lungs, which occurs at high altitudes. 10,000 feet is a typical guideline, but this may be lower at night or if the person is in poor health. Secondly, we can have anemic hypoxia. In this case, there is sufficient oxygen in the lungs, but the blood cannot carry it due to perhaps a hemoglobin disturbance or some other sort of similar pathology. One of the prime examples that can affect us is carbon monoxide poisoning, where the carbon monoxide ends up binding to the iron atom in the hemoglobin molecule. And because there is already a carbon monoxide molecule bound to the hemoglobin, oxygen cannot bind, and therefore oxygen cannot be delivered to the cells. And this is been a factor in a number of crashes. It's also the reason why there are something called airworthiness directives on the exhaust system of a lot of aircraft. If these aircraft, the way the exhaust system works in the heater system is you have a shroud around an exhaust. Fresh air comes around the exhaust pipe and goes into the cabin to heat the cabin. However, if there's a crack in the exhaust gets into the cabin, and of course there's carbon monoxide in there in the exhaust, and the person can end up with carbon monoxide poisoning. Stagnant hypoxia is when there's insufficient blood flow to the cells, such as atherosclerosis, arterial sclerosis, and varicose veins. So a narrowing of the arteries, therefore preventing sufficient perfusion to distal cells. Lastly, histotoxic hypoxia is when cells are unable to utilize oxygen in the red blood cells, such as when there is drug or alcohol impairment. Typically, this hypoxia gets worse with altitude. Now, there is a big difference between what you feel and what others observe when you are hypoxic. Typically, when you are hypoxic, you feel great. You think you're doing a great job flying the airplane. Everything is going just fine. However, what others perceive is anything but. So typically you might think of the example given, oh, I'm doing great. I'm flying this aircraft great. I'm the king of the world. Everyone else looks at it and goes, this guy sucks. It's terrible. They're confused and impaired. Physically, though, you might be a bit dizzy, a bit nauseous, a headache, and have increased respiration, poor coordination, and in very severe circumstances, unconsciousness. Your vision might become tunneled or blurry, and you may become aggressive. If you ever have an opportunity to go into a hypoxia chamber, I believe the military offers that, and sometimes they allow civilians to do that. And what they do is you get put into a big chamber, and slowly they start sucking the air out of it. And you sit in there, and they give you a number of tasks. And it's actually quite funny. If you have an opportunity, just go on YouTube and look up a hypoxia chamber and see what the people are doing, because they sit there, they're kind of giggling, they think they're doing great, and then they're asked to do very simple things like write the alphabet or draw a clock. And then they take a picture of how the clock looked like, and it looks like somebody drew it that is severely demented. Another subject under the hypoxia and hyperventilation is that of time of useful consciousness. This is the amount of time at a certain altitude that you can do tasks to a satisfactory level. So, for example, putting on an oxygen mask. Once you can't do that anymore, you're beyond your time of useful consciousness. You might still be conscious, but you can't even get your oxygen mask on. If you're in for an interesting read up on the golfer Payne Stewart's crash. He was in a Learjet, a passenger in a Lear business jet. There was an explosive decompression. The pilots did not get their oxygen masks on time, and unfortunately, everyone succumbed to their injuries. Because that aircraft was not responding to air traffic control, after some time, the US military sent up some fighter jets to intercept the aircraft, and they just observed frosted over windows, which would be indicative of a very cold cabin with no oxygen. So as you can see here, if you're cruising at 30,000 feet and you lose pressurization, you have between 45 and 75 seconds of time of useful consciousness to get on your oxygen mask. However, if you're above 45,000 feet, that time decreases to 12 to 15 seconds, which is not very long at all when you consider that there's going to be a shock factor after you lose cabin pressure. Both smoking as well as poor physical activity are contributing factors that affect hypoxia. Hypoventilation occurs when the breathing rate is too fast. What happens here is that there is too much oxygen in the lungs and insufficient carbon dioxide, increasing blood acidity. Now you might think, oh, that's not too bad, there's too much oxygen. However, when the brain senses that there's too much oxygen and insufficient carbon dioxide, and the blood is more acidic, it constricts the arteries to the brain, reducing the blood supply. The trick to overcoming hyperventilation is consciously reduce the breathing rate, even though it may be uncomfortable, or start having a conversation. Gases are known to expand and contract with altitude. Obviously, at higher altitude, gases expand. At lower altitude, they compress. In the body, there are a number of sinuses, kind of openings or cavities within a bone, as well as you have an inner ear. And gas can usually freely exchange in and out, although the openings are quite small. So if the body cannot equalize the atmospheric pressure, you may end up with problems. For example, barotitis occurs when the eustachian tubes, those small tubes inside the ear, become blocked from a cold. What ends up happening is pressure builds up behind the eardrum, causing an extensive amount of pain, and in some cases an eardrum rupture. To solve this, you can chew gum, you can yawn, or do the Valsalva maneuver, where you close your nose and mouth and try to blow out. This increases the pressure inside your ear and hopefully will equalize the pressure and open the eustachian tube. These problems often occur in a descent, and so you may find that chewing gum or yawning during a descent helps unblock if you have a blockage in your ear. Dissolved nitrogen in the body forms bubble as the pressure decreases. These bubbles can block capillaries, blocking blood to and from the tissues. It is more prevalent in obese individuals. This is especially important for people that scuba dive because there is a great change in dissolved nitrogen when scuba diving. Generally, the rule of thumb is that you want to wait 8 hours between scuba diving and flying when you do not need to decompress during a dive, and you have to wait 24 hours for dives where decompression was required. Let's talk about visual scanning techniques. When you're flying VFR, it's your responsibility to avoid traffic and terrain. So if you're looking for traffic, you don't want to just scan the sky in one continuous motion. You're likely to miss observing conflicting traffic. Rather, you're going to look at one point in space, focus, and then move your eyes to another point and have individual sectors to look at. Aviation or flying aircraft is inherently loud. Aircraft engines are loud. They generally don't have mufflers, and to keep the airplanes light, they don't put much anti-noise insulation in the aircraft. This noise causes fatigue and hearing loss. The best protection against noise is to buy a good headset. I typically recommend, if you can afford it, an active noise canceling headset. There are many brands out there. I'm somewhat partial to Bose headsets as well as David Clark. They typically last the longest. They are high quality. They are expensive, but I have a David Clark headset that's lasted me about 25 years and it's still working fine. Ordinarily, when we're walking down the street, we are oriented. We can readily identify which way is up, which way is down. We can get this information by both our eyes and our ears. Even if we were to close our eyes, our inner ears would tell us that we're standing up, and we could probably keep standing even though our eyes are closed. However, what can happen is if the cues from the eyes and the ears don't correlate, this spatial disorientation is a loss of bearing or confusion concerning one's sense of position or movement in relation to the surface of the earth. So if we look at this picture that we have right here, on the left, we have the inside mechanism of the ear on 3 axes that will give us information on roll, pitch, and yaw. There is fluid in these ear canals that tell our brain what is going on. However, you can become disoriented when the cues from your eyes and your ears don't align. An example of this disorientation is called Coriolis effect, the opposite turn illusion. It is caused by an inner ear disturbance. So let's just say that we are in a steady turn. We recognize that we go into the turn, and we can say, yeah, we're in a turn. But eventually, the fluid reaches an equilibrium in the ear, and it doesn't feel like we're in a turn anymore. Now, all of a sudden, we suddenly stop the turn. We straighten out, roll into a straight, level attitude. And now the ear, because of this deceleration turn, the fluid in the ear moves in the opposite direction and gives the illusion that now we are turning in the opposite direction. What can happen, let's say we are flying in cloud and we don't have our eyes to reorient our brain, is that we go back into the turn because that is what feels most natural. Of course, this turn unfortunately ends up as a spiral dive and hopefully not a crash. As an example, you can do this in an office chair at home. Here's a video that you can watch of these US Air Force pilots doing this in a disorientation chair, but an office chair at home will suffice. As you can see, what they do is they slowly turn the chair with the gentleman crouched over, closing his eyes, and then all of a sudden they stop. The man moves his head up, and you can pretty much guarantee the person is going to fall out of the chair.
Good.
What's really good, sir, if you introduce those other axes in your semicircular canal, what you can do is go slowly rotate your head the other opposite direction.
Oh.
In a couple seconds, that spinning sensation should go away. All right, and I'll stop the chair on the count of 3. 1, 2, 3.
Oh my god. Still dizzy.
Another disorientation is the somatogravic effect or false climb illusion. I took this cartoon here from Bold Method. If you want to check out their YouTube channel and their website, they have a lot of good aviation information. So this is the diagram of the otoliths in the ear, which help tell your brain which way is up or how things are accelerating. When you're upright, these otoliths are upright. When you accelerate or your head is tilted back, they move back. What ends up happening, though, is that when you accelerate, it feels like you're tilted up. I'll show you here in the next slide what happens. Let's say we're flying slightly nose down, like on an instrument approach. And then we have to do a go around. We're still in cloud, we apply full power. The aircraft, and let's say we pitch up slightly. But because we're accelerating, it feels like we're really pitched up nose high. It feels too high. So what we do instinctively is push forward on the controls so that we're not quote unquote pitched up as high. However, this causes a greater acceleration, making it feel like we're pitched up even more, and we push forward more and more. And so the sensation is that we're climbing more and more, but the reaction is to keep pushing forward more and more, and we end up pushing the aircraft right into the ground. Let's talk about G-forces. G-forces, the ratio between the load factor that you are experiencing and Earth's gravitational constant, 9.8 meters per second square. When we have positive G, we happen something blackout. Negative G causes something called redout. On the right, these were some experiments that were conducted on this Air Force pilot on an acceleration sled, I believe early in the Cold War in the 1950s. And they just kept subjecting him to greater and greater G just to see what would happen. And as you can see, he does not look to be too comfortable. On the left is an effect of negative G, where you end up having a lot of blood pooling in the upper extremities. Eventually, some capillaries may burst, and you end up with these little red spots. Sleep and fatigue is the most common physiological problem for commercial aircrew. The reason for this is because of the frequent time zone changes, as well as often a minimal stress or minimal sleep in between flying shifts. Fatigue is caused by poor sleep, nutrition, stress, noise, vibration, monotony, and personal issues. Pretty much everything that an airline pilot would be exposed to. One of the problems with fatigue is that pilots may not recognize that they are fatigued. they may feel that they are not tired at all. However, the symptoms of fatigue are not necessarily that you feel tired, but they are that poor performance, irritability, and that you tolerate low performance. So I've noticed this when I've been fatigued. I'll be flying, and typically I'd like to think that I fly to a very high standard. And I'm tired, and I don't necessarily feel tired, but I start making little tiny mistakes. And instead of correcting those mistakes, I just sit there and I go, yeah, it's good enough. Yeah, whatever. It's at that point that I know I'm fatigued and I shouldn't be flying anymore. We can divide fatigue into two different categories. Acute fatigue caused by a lack of sleep. The solution to this, you get a good night's sleep and a meal, and hopefully you're good to go. In contrast, chronic fatigue is caused by repeated changes in the circadian rhythm and poor sleep, pretty much something that airline pilots is part of their job description. Chronic fatigue requires long-term changes to the sleep pattern to recover and may take several months to recover. As a personal note, I suffered from chronic fatigue about 6 years ago or so. Took a trip to the doctor and probably about 3 months of treatment until I was back to my normal self and I was no longer fatigued on a regular basis. What clued me in that I had a problem with chronic fatigue was that I was sleeping 9 hours a day, but not feeling rested. I would go to bed, let's say at 10 at night. I would lay in bed until about midnight, not being able to sleep, sometimes later. I would wake up at 8 or 9 in the morning, and then I would just kind of hang out in bed for 3 hours reading the news or checking my email. And it wouldn't be until about noon that I'd actually be getting out of bed, having a shower, and being productive. It's at that point that I realized that I had a chronic fatigue issue and I had to seek medical help. Anesthetics obviously interfere with flying performance. They are meant to render you unconscious, consciousness being a prerequisite to flying an aircraft. So there's obviously conflict. If you get a local anesthetic, such as a dental procedure or sutures, you should wait a minimum of 24 hours between the anesthetic and flying. If you get general anesthetic, following a surgery, for example, you should wait until you're cleared by your physician to fly. If you donate blood, you should wait 48 hours prior to flying. Let's have a quick review. Hypoxia is a lack of oxygen delivered to cells. There are 4 types of hypoxia: hypoxic, stagnant, anemic, and histotoxic. The body needs to equalize pressure inside and outside of the body. Flying with the cold can prevent the equilibrium of gases and therefore cause barositis. Eyes and ears provide orientation. When these two senses don't agree, disorientation occurs. This can result in flight false climb illusions, the somatogravic illusion, which causes a pilot to nose down during acceleration. You should wait 24 hours following local anesthetic before flying, or until cleared by your doctor in case of general anesthetic. You should wait 48 hours following blood donations before flying. Let's work our way through some practice problems. First one, any pilot who has had a local anesthetic for extensive dental procedures should not act as a flight crew member for the next. Well, this is basic memory work. We said it's 24 hours. B is correct. Relatively small amounts of alcohol affect tolerance to hypoxia, a lack of sufficient oxygen. This tolerance, A, deteriorates with increase of altitude, B, improves with increase of altitude, is not affected by altitude change, and D, remains constant to 6,000 feet. Remember, not very many things get better with altitude. This is one of them. The correct answer is A, it deteriorates with altitude. With regard to fatigue, which statement is correct according to the information given under the medical information section of the Transport Canada AIM Canada? A, financial or family problems do not influence tolerance to fatigue. Well, we know that's not correct because problems do influence tolerance to fatigue. B, fatigue slows reaction time and causes foolish inattentive errors. Yeah, that's probably correct. Let's continue. C, a fatigued person recuperates more quickly as altitude is gained. No, it's the opposite. D, A fatigued person must have food immediately before and during a flight. No, they also need sleep. So, working our way through it, the correct answer B. It slows reaction time and causes foolish, inattentive errors. A pilot who has donated blood should not act as a flight crew member for the next basic memory work. The answer D. 48 hours. Any pilot who has had a general anesthetic should not act as a flight crew member. A, during the next 12 hours, B, 36 hours, C, 48 hours. Their correct answer, D, unless advised, it is safe to do so by a doctor. Clearing the ears on a rapid descent may be assisted by A, swallowing, B, opening the mouth widely or yawning, C, a Valsalva maneuver, or D, all of the above. So we went through all of these. You can swallow, you can open the mouth or yawn, that works, or the Valsalva maneuver where you close your mouth and plug your nose and try to breathe out. So all of those work. The correct answer is D, all of the above. Flight crew members who require decompression stops on the way to the surface when scuba diving should not fly for. So this is basic memory work. If you recall, the correct answer D, 24 hours. A flight crew member aware of being under a physical disability that might invalidate license issue or renewal shall A, so advise the minister. So that's probably a good idea. B, not commence a flight as a crew member. C, forward the license to the regional medical officer. D, flies a flight crew member if a backup member is available. So C and D, you can probably eliminate. A and B are actually both correct, but the most correct answer is you should advise the minister, and they can make a decision whether you should commence a flight as a crew member or not. What is the recommended treatment for hyperventilation below 8,000 feet? Remember, hyperventilation is caused by breathing too fast. So we can increase the depth of breathing, hold the breath and perform a Valsalva maneuver. No, that's what we do when we have during a descent to clear the ears. C, slow the breathing rate to below 12 times per minute. D, increase oxygen flow rates. So the correct answer would be C, hold the breathing rate to below 12 times per minute. That concludes our lesson on aviation physiology. We will continue with the next lesson in human factors. See you there.